with the pancreatic cancer patients, I tell them right from the get-go that the likelihood for an advanced cancer that can't come out because the surgeon says so to all of a sudden now become resectable is only about 10 to 20%. In some cases where it's maybe less advanced but still a high risk for not being able to get it out, that's about 50%.
What's that conversation like?
So I tell them, I said, look, it's a 50-50 shot. If the surgeon can't get it out, we're going to continue to monitor. We may recommend doing more chemotherapy. What I tell them now is, now that I'm able to offer you this 1 week treatment, it's not that I put you through 6 weeks of treatment for nothing. We're doing this 1 week treatment, which I think is as effective and more likely to control the tumor, and you'll have a lot less side effects from the treatment. But it's not going to shrink for at least 3 or 6 months. And then when I bring them back for 1 month and I said, well, the tumor's stable, nothing changed. And they're like, what? I'm like, remember what I told you yeah, you did. And then they're like, oh yeah, okay, you did mention that. So I'm like, I'm not surprised by this. This is kind of what we want. And now it's up to the surgeon to see if he can take it out. So I kind of toss it back to the surgeon. But then if at that point, my role is really limited, but I still follow them for side effects. I'll give you 2 examples. Like I treated one patient 3 years ago with this 5 treatment. He wasn't healthy at all for surgery. He got his chemo. We did the 5 treatments of radiation. I saw him a couple of times, and then basically he just continued to follow with the medical oncologist. The scheduler about a month ago said, hey, there's this patient here. He wants to see you. Can you see him? I'm like, who is it? So I type his name, like, oh, that's the patient I treated 3 years ago. It's like, wow, what does he want? He goes, oh, he just wants to thank you. He's like been disease-free for 3 months, for 3 years now. And his last set of scans look great. I'm like, yeah, throw him in the room. Let me go talk to him. So that was very encouraging. But also last year, a patient that I treated in the summer, I got an inpatient consult. He was admitted to the hospital, and 3 months later, and it turned out because of the treatment, I ended up causing a severe ulcer that perforated his stomach, and he needed surgery to correct. And then also at that time, his cancer had spread to the liver too. So he had a very aggressive form. So he had he had progression of disease as well as complication related to the treatment. I sat down with them, had a very long conversation. They were actually, interestingly, saying, very thankful that I was able to treat them and see them and potentially consider additional treatments for them. It was like, we knew that this was a possibility. You told us. We don't blame you. We know that this was an issue, but that's the bad, right? You think you're giving the best treatment, you're giving it, but then you cause the complication, and that's always what we try to avoid. That complication is on the order, fortunately, of only 5%, but unfortunately, someone's going to end up with that complication. So,
I interviewed Dr. Garagazlu several months ago, and he said that when a doctor makes a mistake with the patient, or if the doctor can't save the patient, or the negative news needs to be given one way or the other, if you sit with the patient and look them in the eye and you speak the truth to them, they understand.
Yeah, and I have to agree with that assessment. And it's hard. You get the results and they're in there and you're like, okay, so I'm going over, and that's another thing. I'm like going back and making sure everything I did was on par. And then I go in and then, sit down with them, chat with them a little bit, find out how they're doing, find out if they've seen the results of the scans, and then slowly go into it. It does take a balancing act. I've had most patients are very understanding. They know that some bad news is going to happen. I've had one patient that was so angry he just burst out of the clinic, slammed the door. And that's also it's not an improper response. I mean, you're telling someone, hey, look, I can't treat you, or the treatment didn't work, and you really literally have like 3 months to live. That's not an easy conversation.
Existentially horrifying for the person across the room.
Yeah. And during med school training, residency training, you learn how to do patient interactions, but until you're out in the clinic yourself and they're your patients, everything you learn basically goes out the window, because now this is your clinic and you have to figure out how you're going to proceed. So my thing was, I want to be upfront, not brutally honest, but I want to be upfront, let them know everything that can happen, let them know the potential outcomes. Like, I'm usually the first one after like 5 or 6 doctors that they'll say, well, what's my prognosis? What's my likelihood of living? And I'm like, I'm going to quote you statistics that apply to 100 people. And I can say, at 5 years, 30% are still alive. But I said, when it comes to you, it's still 50-50. We have to do the treatments. If you have a very good response, you're going to live a lot longer. If you don't, your prognosis is dim. And that's also one thing they don't kind of teach you in medical school and residency.
To tell someone that they're going to die.
You're quoting statistics. Statistics apply to a population. The individual, it's always 50-50.